individuals that we're working with that medication may be really appropriate for. A little bit about me. My name is Monica Forbes. I'm a nationally certified peer recovery support specialist. I'm an Idaho certified recovery coach supervisor, Idaho peer support specialist trained. I did not get my certification in Idaho for that, just simply because I didn't have the I need to, and the national certification kind of encompasses both of those. But I have been a medical assistant for over 30 years. I am a subject matter expert on recovery support services, an NIDA Addiction Policy Forum trainer, certified community educator for the Addiction Policy Forum, and my favorite role is this. I work currently as the CEO of Recovery United, which has been running recovery community centers and providing recovery support services for 8 years. I am a person in long-term recovery. So when I say I'm a subject matter expert on opioid use disorder, I am really a subject matter expert on opioid use disorder in that I am 18 years in recovery from my opioid use disorder, and also a 3-time accidental overdose survivor. So this is something that's very near and dear to my heart. It is the purpose and passion that drives all the work that I do in this field. That's my email address there if you want to get in touch with me. Again, all of these slides, as she mentioned, are over in that under handouts in that little box up in the upper right hand corner of the screen. So would love if you would be able to download that and be able to reference the information that's in it. As she mentioned, this presentation is being brought to you by Empower Idaho. The material that we're going to be going over today is reference material that has been provided by C4 Innovations. That's their website if you want to learn more. The Addiction Policy Forum, Praxis, and Peer Recovery Supports of Idaho. And without further ado, we'll just take a look at what it is we're going to be talking about today. The main goals of what we're going to cover and touch on very briefly in each one of these sections is understanding opioid use disorder. How does the brain even get hooked on opioids or opiates? How is opioid use disorder different from other substance use disorders? And if you've ever asked yourself the question, you probably hear these words used interchangeably. What's the difference between opioids or opiates? So we're going to talk about that. What do the stages of opioid use disorder look like? And what are some of the risk factors that exist and make it easier for somebody to develop opioid use disorder? We're going to take a look at some of the data and statistics, and we're going to take a look at understanding what medication-assisted treatment is. What are the medications that are used? What are the typical stages that are involved with medication-assisted treatment? What are the risks and benefits of medication-assisted treatment? And what are the expected outcomes? What are the studies showing us as far as how effective they are in helping someone? We're gonna, if we have time, because we do just have 1 hour today, I do want to take a look at exploring prejudice, biases, and myths that surround medication-assisted treatment, because I know that if you work in this field, you've heard some of these. And I think it's important to address those in our role as peer supports. So those are the things, and you might see here that MAR, the abbreviation MAR, there it's referred to as medication-assisted treatment or medication-assisted recovery. So if you are reading notes or getting an email from someone and they're talking about MAT or MAR, it's really the same thing. So in order to understand opioid use disorder, I think we need to take just a few minutes and take a look at all substance use disorder. How does it affect our brain? Addiction, which is a word that if you are part of the Language Matters community, it may rub you the wrong way, because the word addiction sort of came to almost be a derogatory label. And so you'll see quite often a lot of us are substituting the word substance use disorder, but the word addiction was what started a lot of the work and studies that and the diagnosis that was originally given in this. So you're going to see the word addiction used quite a bit. Please forgive me. When I'm in normal conversation, I usually use the word substance use disorder or a person who has substance use disorder, but the materials that are being provided are going to use both words. But basically, addiction is a disease of the brain, and it's the most severe form of substance use disorder. It is called a brain disorder because it actually creates anatomical and physiological changes within the brain. That means that it changes not only the anatomy of the brain, but it also changes which parts of the brain are affected and how they function. It's, sorry, I'm going to my notes here for the next slide. There are actually 20 different substance use disorders listed in the DSM-5. Here's the most common ones: alcohol use disorder, opioid use disorder, tobacco use disorder, sedative, stimulant, marijuana, hallucinogen. But I think it's very important to note that quite often, more often than not, it's actually most of the clients that we tend to be working with have what we call polysubstance use disorder. That means there's more than one substance that is being used and or abused by the individual. Addiction by the numbers, there are over 20 million Americans that suffer from substance use disorder. There's approximately 23.5 million that are in recovery. Being that it is September and Recovery Month, I think that's an important statistic to really focus on, because it reminds us that treatment works, recovery is possible, and we're worth it. But we do know that on average, 1 in 7 people will struggle with some form of substance use during their lifespan. This is a video that really kind of explains how the brain gets hooked on opioids and gives a little bit of a history. It is a 5-minute video that was put together by pbs.org. We were having some technical difficulties and also some time issues on including this video in today's presentation. But because that link down at the bottom of the screen is functional, if you do download the PowerPoint slides from today, I would urge you to take 5 minutes of your day and take a look at that video. I think it does a really good job of putting how opioid use disorder can happen into layman's terms and easy to understand concepts. And so it's something I really highly recommend taking a look at if you have the time. This slide is like a half slice of the brain, and it shows some of the neural pathways that are affected when an individual is using opiates or opioids. The yellow pathways there are dopamine pathways. As you can see, they kind of start there in the center of the brain. They kind of flow up through the prefrontal cortex or the frontal cortex of the brain. And dopamine, if those of you who aren't familiar with that neurotransmitter, is our happy hormone. When we're happy and satisfied and doing things that our survival mechanism in our brain tells us we should do in order to survive, those are the pathways that the dopamine goes and the parts of the brain that those neurotransmitters affect. Serotonin is the orange line that you see going through there. Again, it sort of starts in the midbrain, goes up through the frontal cortex, and then through lots of other areas, almost the entire area of the brain, right? Those serotonin neurotransmitters are also affected by substances when we use them. So the function of serotonin and what's going to be affected when someone is using or abusing a substance are functions like mood, memory processing, sleep, cognition, or the way that we think. Those are kind of really important parts of our brain, and they are being affected by the substances that we're using or abusing. But rather than just take our word for it, one of the things that was the most exciting progress, I think, that was made in our field was back in 1994. Doctors Volko and Shelbert in 1994 started taking PET images of the brain. Prior to this, all we could see was what was going on the outside. We saw the behaviors. We saw people choosing to use or abuse substances, but we didn't know why. We also saw how the use and abuse of those substances affected that individual's behaviors and their ability to function. And I kind of liken that to, before we had x-rays, let's say somebody fell and their leg hurts. Before we had x-rays, you would take a look at the outside of the leg and you'd be like, well, it looks fine. I don't see anything. So, just get up, walk it off. There's nothing wrong. I can't see anything wrong with you. So you should just be able to get up and walk. Then we developed x-rays and we were able to go in and take a look at the bone, right? And we'd be like, oh, wow, I see that hairline fracture there. Wow, yeah, you have a broken leg, dude. So I think that what we need to do is, let's support it, wrap it up in a cast, and let's get you off your feet. You need to rest it, elevate it, put some ice on it, give it some time to heal. And, 6 weeks, we'll take the cast off and you'll get up and start walking and you'll probably be almost as good as new. But until we had the ability to look at that x-ray and actually see the fracture from the outside, it could be perplexing. Like, why aren't you just walking? Why aren't you just getting over it, right? Apply that concept to being able to go in and look at brain images and see what's actually happening when somebody is using or abusing a substance. So what they discovered, and you can see here in these pictures, that they had decreased metabolism, for example, in the cocaine use disorder patient here. We had a control which was normal. All those yellow are really active areas, and there's not so much yellow over on that top image on the right, because those parts of the brain were not able to function normally because that substance was in there. But why was it affecting the brain the way that it was? Why was that decreasing the ability of the brain to act the way it would if they weren't using substances, if that makes sense? What they discovered is that there were a lot of changes when someone was under the influence of a substance, and two really, really important parts of the brain were being affected. The limbic system, which is in the midbrain. The limbic system in our brain is the part that it's our survival part of our brain. It's sometimes referred to as the lizard brain. It's the part of our brain that rewards us for doing things that help us survive. The cortex, up here in your forehead, is where we do higher functioning decision making, thought processes, evaluating risk, controlling impulses. Okay, so these are the two main parts of the brain that were being drastically affected by the use of substances. To put that into a little bit clearer context, if I can, the primary motivations that ensure survival are breathing, drinking water, eating food, seeking shelter, procreating, having social connections. All of these things, whenever we do them, the limbic system releases dopamine and says, good job. I'm going to reward you for doing this because it's going to help you stay alive. And the more you do this, the longer you will live. Well, what happens when we take these substances and that part of our brain is being affected is that basically that survival mechanism, the limbic system in our brain, is being hijacked and kidnapped by the substance that we are using or abusing. It gets into the limbic system and inserts itself as one of the survival skills and things that we need to do in order to survive. To put that in layman's terms, essentially, what we're saying is this drug, what it's done when it's kidnapped and hijacked our brain, is that we need that drug to survive. We need that drug just as much as we need water, sleep, shelter, food, air. And if you've never looked at it this way before, I hope you stop and think about how that's going to affect your behaviors. Even if it wasn't for you, maybe it's the clients you're working with or someone you know or someone even maybe in your family. Why would they continue to use despite negative consequences? That's the question everyone asks. Why are they using? This is the explanation. This is why they are using or abusing substances. The survival mechanism of their brain has been kidnapped and hijacked by that substance. And it also compromises the cortex where we're making decisions, where we're trying to, I'm sorry for going to the next slide too soon. It's how we control our impulses, how we evaluate risk and benefit, how we conduct ourselves and the decisions that we make. And I hope that kind of gives you a little bit of context as we move into what else is going on in the brain and in the body of someone who's using opiates. Everything that we are showing you here, like these brain scans, I'm not a doctor. If I haven't made that clear, I'm not. I'm certainly not qualified to talk about, or, evaluate and read x-rays or brain scans or anything. But when the doctors tell me what this is and what it says, I can share that with you. So on the left, we have a healthy person. And the normal function are those yellow and red areas and a little bit, the green. When you look at someone who's been utilizing methamphetamines, 1 month after they quit using, that's what their brain scan looked like. There's no red. There is, the red shows a lot of activity, but there's not a lot of activity in this portion of the brain, even a month after they quit using. But 14 months later, after abstinence, they're no longer using methamphetamines. Look how the red function, the brain healed, it came back. And that's what's one of the most beautiful things about our brain, our bodies, and just ourselves as a whole person, is that we do have the ability to recover. We can get better. And I think that's one of the most hopeful things that we can hold on to as we work in this field. Before I get into opiates and opioids, were there any questions, Alejandra, or comments?
Yeah, actually, we did have a question come through. It's, what is the most important thing, in your opinion, to keep in mind about people who have addictive behaviors in their family's history, and how can that affect their lives for good or bad?
That's a very deep question. What is the most important thing to keep in mind is that it's not a choice. I do not believe that developing any behavioral health disorder is a choice. And if we remember that it's actually a chronic disease, and it changes how we look at that person. It changes how we interact with them and the regard that we have for them. So I would have to say, this is my personal opinion. This is not fact, but my personal opinion is that if we can remember that nobody chose to develop substance use disorder, but they can choose recovery, maybe we're a little less quick to find fault with them or to blame them and look at it as a character flaw or a moral failing, and look at them as an individual who has a disease. Does that mean that we excuse behaviors that are negative or harmful? No. It just means that we understand that their brain is not functioning properly right now. I'm still going to have healthy boundaries, and there's still going to be consequences for my loved ones or my clients' actions, but I can still look at them as a human being with intrinsic value, and as someone who has the potential to get into recovery and maintain recovery. I hope that was helpful and what you were looking for.
Thank you, Monica.
So, the difference between opiates and opioids. This picture is going to kind of show you what the difference is between the two. But first of all, there are 3 ways that opiates are made and opioids. First of all, number 1, did you know that your body actually creates opioids? It has a built-in pain reliever in our bodies. And if you don't believe me, stub your toe. If you just wait like 5 seconds, all of a sudden it doesn't hurt as bad, right? That's because your body, the minute it recognized pain, it went, oh no, and it put those it's called endogenous opioids, endorphins and stuff. It released that to help minimize the pain, which I'm very grateful for at like 2 o'clock in the morning when I stub my toe on the end of my bed or something, right? But the second way is that they're naturally derived from plants. So the difference between opiates and opioids are that opiates are derived from a plant-based source. Opioids are either partially or fully synthesized in a lab. So examples, of different opiates and opioids might be, for opiates, opium, morphine, codeine, those are all naturally plant-derived sources. Opioids are things like heroin, hydrocodone, hydromorphone, oxycodone, oxymorphone, buprenorphine. Remember that one, make a mental note. We're going to talk about a little bit more about buprenorphine here in a minute. Then I have to move my little square over, sorry. Synthetic opioids would be, those are either partially or completely synthetically manufactured in a lab or who knows where, but like fentanyl, methadone, and tramadol are examples of synthetic opioids. Whoa, I'm sorry, I'm having some issues with my computer here and the screens that are showing. I apologize for clicking so much on that. But so the stages of opioid use disorder are, first, a physical dependence. Now, that means that I've been taking opiates or opioids probably for a short amount of time. And when I stop taking the medication or the other, street drugs or whatever it is, I'm going to have physical withdrawal symptoms. Those common symptoms could be like muscle pain, muscle aches. It can be nausea and stomach and GI upset, stuffy nose, runny eyes. A lot of people, and I'm going to tell you from experience, having gone through opioid withdrawals, it's like having the flu times 1,000. So those are some signs. Now, they're not always that extreme. You might take opiates for, maybe 10 days. You had surgery or whatever, you were in an accident. So you take those medications and you stop taking them, and you might have a little bit depressed mood. You might have the GI upset, kind of stuffy nose things, but you go on with your life. You get through it in a day or two and you're back to normal. The second stage of opioid use disorder is when you've built up a tolerance. That's where you actually create in your brain and in your body physiological adaptations, which means there were actual changes in the function of your brain and your nervous system. You have a tolerance. That means, like, when you first started taking an opiate, maybe 5 milligrams was great, but after you've used it for a while, it's not enough. And you're starting to experience pain again. And we have a doctor that we work with up in McCall that explained that our body needs to feel pain. So when we start blocking those opiate receptors by taking an opiate, the neuroreceptors in our brain say, hey, I'm not feeling pain. I need to feel pain so I know when there's danger. So I'm going to create some more receptors. And that's literally what causes us to develop a tolerance to the opiate that we're taking. Those can go away after abstinence or with medications, but It also explains why sometimes when people are trying to stop taking opiates, they develop it's called hyperanalgesia, where you feel pain a lot more. At any rate, we've been taking opiates for a period of time, and now the amount that we were taking isn't working as well now, and we want to take more. That's the tolerance stage of opioid use disorder. The third stage is when I've now developed substance use disorder. I have a compulsive use of this drug, and I'm probably exhibiting what they call maladaptive behaviors. Those are things that are creating negative consequences, things that may be getting me in trouble, that have me drug seeking, that have me calling into work, that in my case, I can tell you from experience, my entire life revolved around keeping that drug in my system. There wasn't room to go to work because it wasn't even to get high anymore. It was just to not be sick, right? But if you've gone all the way past physical dependence, past tolerance, you've developed full-blown substance use disorder, those are the type of things you're going to see in that stage. Are there any questions on this part of the presentation yet?
Thanks, Monica. I'm taking a look at the questions box right now. And we have one that was sent to us a couple minutes ago. What if the reason you started stimulants was and is valid, but has turned into addiction? How do you recover and still address the initial issue? Oh, and it looks like you're muted, Monica.
Sorry, I was like, those are really great questions. That is a complicated thing. And I'm going to talk about similar. Imagine it wasn't stimulants. Imagine you have chronic pain. Maybe you broke your back, or you have some neuromusculoskeletal issue going on that's causing chronic pain, and it's definitely affecting your quality of life. So if you can reduce the pain or manage the pain, that makes it so you can function. But then you develop opioid use disorder. How are you supposed to just stop using opiates and be in pain for the rest of your life? Those are very individual. The answers to that are going to be very individual. It's going to depend on the team, the doctors, the treatment providers, the individual themselves being an informed consumer, and figuring out what's going to work for them going forward. That's the only answer I can give you right now. But it is the question of the year. We don't want people to think that recovery means that they won't be able to function. Let's say you have ADHD, right? And so you're taking a stimulant. There's a lot of different options and education going into the medical and behavioral health community right now that are helping those professionals find the right solution for each individual. And more is being learned every day. So there's definitely hope. I hope that adequately answers your question.
Thanks, Monica.
You're welcome. Okay, so what are some of the risk factors? These are some of them. Sometimes heredity. I don't know why they put willpower on there, but what I think they meant, this was a list that was taken from the National Institute of Drug, NIDA. They said, I asked for an explanation on that, and they said it's not that we are saying that this person has strong willpower or doesn't have strong willpower. It's the ability of that person, where their brain's at, in impulse control. That definitely has an effect on some developing risk factors for or risk factors that are there to present that increase the risk of developing a substance use disorder. It could be the environment. It could be the modeling that you have in your family or your social circle. Age of first use is a huge indicator and huge risk factor. We're finding out that because the brain is still developing up until about age 21, the earlier that a mind-altering substance is introduced into the brain, it goes from like a 0.25 chance of developing it to over 75% chance of developing a substance use disorder when a mind-altering substance is utilized prior to age 21 or before the brain is fully developed. Having an underlying co-occurring behavioral health disorder or mental health disorder. Childhood trauma, we all know that to be a very significant factor. But at the end of the day, what we're looking at with substance use disorder is that it's a biopsychosocial disease. It's not just biological, it's not just psychological, and it's not just social. It's how each one of those individuals, each one of those individual areas affect each other in that individual person's life and in their brain and in their body. There's no one thing that causes it, but there are some indicators that can show us that we might be at higher risk, if that makes sense. So what goes up must come down. We were talking about those risk factors and, whoops, trying to move my thing around, prolonged deficiencies of having the brain having to create its own opioids, create a situation where we have, sorry, I'm trying to look at my slide here and read that. You've been using it for a prolonged amount of time, the brain's capacity to regulate mood becomes compromised. So that's even going to be even worse if you have a pre-existing condition like depression. And then you have this whole thing like, which came first, the chicken or the egg? Was I depressed and self-medicating by using substances, but I'm utilizing this substance and now my depression is worse, and while my depression is worse, that's going to increase my substance use. It can become this whole vicious circle. And I did a presentation last week to the Idaho Juvenile Justice Association explaining it doesn't really matter which one came first. What matters is that we have two distinct things going on that are feeding into each other in a negative way, and the only way this person is going to get into recovery and be successful is if we address both of them. But because we are, if we're abusing this substance, we're getting into this cycle and we're making whatever pre-existing condition may have been there, we're making it even worse. About 29, we just talked about that really great question that came in. About 29 to 60% of people with opioid use disorder still have to live with something that's causing them chronic pain. I talked earlier about how the neuroreceptors, we're creating new opioid receptors because we were numbing up the ones that we started off with, and that's how tolerance was being increased, right? So sometimes you have an individual who goes, okay, I recognize I'm having a problem with my opioid use. I recognize that maybe I need to get some help. And it's really, really hard for them to stop because they might create a hypersensitivity to pain. And they don't want to be in pain, but the opioids are also not working as well as they used to. So that's exactly the way my route into opioid use disorder went. I was prescribed a medication for a legitimate medical disease. But over time, I built up a tolerance and I just wanted to take more and more and more because the amounts I'd started off with just weren't working anymore. So we end up in a little bit of a vicious circle, but I talk about this just to give you an idea of why it's going to be really challenging and some of the challenges that an individual trying to stop using opiates is going to run into. They might actually feel like their pain is worse than it was before, because it's not that they're making it up. There's a real physiological reason going on in their brain why they're feeling that way and why it's even more challenging to just stop taking the opiates. So when we look at opiates and motivation in that area, most people can't just walk away even when they want to. They can do it maybe for short periods of time, even when there's really severe consequences, right? Long-term recovery is going to require that they deal with the long-term, they deal with the consequences. They have altered brain chemistry. which can cause long-term distress. The brain's motivation mechanisms, I just showed you over there, the limbic system and the frontal cortex, how the drug had gone in there and just basically kidnapped their survival mechanism, right? That's the brain's motivation, and those are being affected by this opiate as well. Research shows, though, that better outcomes require a combination of things. It requires counseling, it requires recovery support, and if they're going to do medication-assisted treatment, at least 12 months on a medication. These are scientific studies that have proven this. This is the best practice when it comes to treating opioid use disorder. What I can't emphasize enough is that I'm giving you general information today. It is not going to apply to every client. It's not going to apply to every situation, because we are all individuals with our own unique needs, history, experiences, bodies, brains, and we cannot take a cookie cutter approach to addressing any substance use disorder, including opioid use disorder. These are just some of the factors that we know affect it, and we're just arming ourselves with a little bit of background and information so that we can provide the best peer support to our clients. So I'm going to recap on that. Chances of success improve when we use everything. Professional treatment services, and maybe the first treatment program they go through was a good fit or wasn't a complete fit, or who knows. If at first you don't succeed, try again. Don't give up just because maybe one episode of treatment didn't work. Counseling, addressing any comorbid mental health disorders. Then we have medications, peer recovery support, family support connections, and connections to the community. SAMHSA, and we all know it's absolutely essential to recovery. And all of their other essential services, mental health, housing, medical care, all of our basic needs. But when all of these things come together, we drastically improve an individual's ability to recover and to get into recovery from opioid use disorder. Before I get into data and statistics, and I do realize I'm going very fast, but you do have the ability to download this PowerPoint and review it at your leisure. And if you ever run into any other questions or want some more information on something, please do send me an email and I'll do my best to get that to you. Are there any questions before we go into some of the data and statistics?
Yeah, we had one question come through. I would like to know your opinion about Suboxone. Is it not one addiction replacing another?
That's an excellent question. And I'd be more than happy to share my opinion with you, but I'm also going to talk to you about science, data, and numbers before I share my opinion with you, if that's okay. But you guys are coming up with like the best questions ever. That is something that we get asked a lot. And I want to be able to address that and talk about it with science, if that's okay. Were there any other questions, or should we just get into it and start looking at the data?
Yeah, let's get into it. Thanks, Monica.
Okay. All right. So data and statistics of opioid use disorder. First of all, the opioid epidemic, we all know we're in an opioid epidemic right now, right? 70,630 people died of a drug overdose in 2019. And sometimes it's hard to collect and get the data reported in time, so I know that was 3 years ago. In that year, 1.6 million people had opioid use disorder, 745,000 people used heroin, 1.6 million misused prescription pain relievers for the first time, just in 2019. 48,006 deaths were attributed to overdosing on synthetic opioids other than methadone. So probably fentanyl, carfentanil, any of the new designer drugs are coming up with. 10.1 million people misused prescription opioids in the past year. 50,000 people used heroin for the first time in 2019. Why do you think that happened? While you're thinking about that, let me tell you what we've been discussing in like the opioid task force. We started realizing that it was really easy for people to doctor shop and to like go get some pills over here and then go get some over there. And there was a disconnect, and people, it was easy for people to doctor shop and obtain more opiates than they really needed to have or should have. So we developed the prescription monitoring program. Idaho became, started in 2017, doing everything they could, following evidence-based practices to address the opioid epidemic as it was back in 2017. And imagine that now there's a prescription monitoring program going on, and your doctor, when he sees you, can go on the computer and see everywhere you were getting prescriptions from and whether or not he was duplicating opiate prescriptions, right? And doctors started becoming very aware of how dangerous opiates were, how addictive they were, what was going on. So we saw this pendulum effect where doctors stopped overprescribing. They started watching and making sure that they were managing this medically and responsibly from their point of view. As that change was happening in the medical community, a lot of people found themselves cut off from their drug supply, which had been, Rite Aid, or well, I don't mean to pick on Rite Aid, the pharmacy, right? Rite Aid was my drug dealer. That's not their fault. That was, my disease. But so we found people all of a sudden, maybe without the proper treatment and recovery supports that they needed in order to actually safely come off opiates, found themselves in acute withdrawals, cut off, almost shamed, whether it was self-shame or feeling that from the doctor's office. They migrated over to street drugs because they had opioid use disorder. They were addicted to this drug. Their brain was telling them they needed it. They couldn't get it from their current supplier, so they migrated over to street drugs. Unfortunately, so for in a 12-month period ending in June of 2020, there had been 14,480 deaths attributing to overdosing just on heroin in the United States. Right now, 251 people die every single day in the United States from an accidental opiate overdose. 75% of the nearly 92,000 drug overdoses that happened in 20 involved an opioid. Just to put this in context. As far as Idaho goes, just here in Idaho, this is the latest graph I could find, but I know we have newer ones. I just wasn't able to pull it up, but well, I was able to. Let me rephrase that. This was the one we had in 2016. You can see the red line is Idaho and the gray line is the US. That's how we compared to the average for the United States. That's where Idaho was at as of 2016. And this was the more current data I got for 2020, where it shows that the national average was 28.3. Idaho was at 15.5%. But to put that, instead of just a percentage, let me give you some hard numbers here. In 2018, 279 Idahoans lost their lives to an accidental opiate overdose. In 2021, despite all the efforts that we've put into community education, prescription monitoring, medical provider training, the availability of naloxone and now Cloxata, which is a double dose of that Narcan to address the more potent fentanyl that we have now in our communities. Despite all of these efforts and everything we've done, in 2021, 353 individuals lost their fight with opioid use disorder. This is a significant problem. It's something that we've got to talk about. It's the elephant in the room. And one of the reasons I'm just very grateful that you're here with us today. The next graph shows the number of opioid-related overdoses. Those yellow bars are the total. Heroin started making a comeback in 2014. The synthetic opioids started coming back in too. But what's significant about this graph is I want you to understand that green line that's kind of following along the top there. Those are prescriptions. In fact, in 2018, one of the doctors that was on the statewide opioid task force shared with us that 2/3 of the accidental opiate overdoses that had occurred that year had been from a prescription. And that's why we started doing provider education, prescription monitoring, community education, and warning people about the true dangers and addictive nature of using opiates, even prescribed. That, I think, to me, that's just a significant number. This is a graph that shows the drug overdose deaths. Again, it is part of the PowerPoint that you can download and refer back to and take a look at. But we are kind of running short on time, so I'm going to try and go a little quickly here and actually get to the medications that are used and hopefully answer that question, that last question that we just got. These are the evidence-based approaches to effectively treating addiction, utilizing hospital residential programs, partial hospitalization programs, intensive outpatient treatment, outpatient programs, detox facilities, opioid treatment programs. When we talk about opioid treatment providers, we're talking about like Raise the Bottom or Behavioral Health Group, which used to be Center for Behavioral Health. Those places where someone goes in every day and is seen and medically monitored every day in order to obtain methadone or buprenorphine, or which is also Suboxone, the key ingredient of Suboxone. And then office-based opioid treatment, sometimes just working with their primary care physician and figuring out how they're going to manage that. These are all evidence-based approaches to treating addiction. But the most effective evidence-based practice for treating opioid use disorder is the use of medication-assisted treatment. It's the use of medications in combination. It's a lot more effective when it's added to treatment and counseling and group and peer support and community support. There are 3 FDA-approved medications for the use of treatment with opioid use disorder, and also includes, one of them also is FDA-approved for alcohol use disorder, and one of them also works for tobacco use disorder. And we're going to talk about why we would use a medication. The question that you guys posed here just a few minutes ago was, are we just trading one drug for another? And so my answer to that is, take a look at this graph. If we have an individual who, despite repeated efforts, is having a really difficult time getting off of illegally obtained or street drugs, or is still abusing their prescription drugs, they're at increased risk for dying. And what we've noticed, and what we do know based on the statistics and the studies, is that medication-assisted treatment makes it possible for them to stay alive longer. We cannot recover if we're dead, right? So they've in the studies, they said that there was a 59% increased ability to get into recovery utilizing methadone, 38% increased reduction in mortality by using buprenorphine, Suboxone. Where did they come up with this information? The way it works, and that's some of the reasons I want us to stop and think about this for just a second, is that one, I'm going to read what's on the slide, but I'm also going to share just some of my personal, since you did ask what my personal opinion was, I do want to go ahead and share that with you. Yes, trading one drug for another. The drug I was getting on the street, I probably had to commit a crime to obtain. I was exposing myself, depending on how I was utilizing that drug, to sexually transmitted diseases and other medical complications like abscesses or septicemia or whatever else. The medications that we received in medication-assisted treatment are clean. They come from a pharmacy. The amount I'm taking is medically monitored by a physician or a prescriber. So that could be a nurse practitioner or a physician's assistant or a psychiatrist. And they're monitoring me. They're doing testing to make sure that I'm taking the proper amount. And the likelihood of me overdosing on this medication that I'm getting from the doctor is a lot less, because they're not giving me a lot of it. The other thing is that I now have this additional support while I'm taking this medication. My urges are reduced, so now I can focus on actually doing the healing that recovery really is. I can pay attention in class because I'm not just, hanging on by my fingernails and going through, really strong urges and withdrawal symptoms, right? So it relieves the cravings to take these medically prescribed, medically monitored medications. Opioid overdoses are the leading cause of death in the United States. If you did not see that in the data I was telling you, it kills more people than car crashes, guns, and violence combined. Right now, it is the #1 cause of death in the United States. If that's not compelling reason enough to put somebody in a safer environment, I don't know what is. Research shows that medication is effective in reducing relapse when it's used in combination with other psychosocial treatment and support. In Baltimore, between 1995 and 2009, they saw a 50% reduction in fatal overdoses just by making medication-assisted treatment available. That's just something to think about. So the general principles, I'm going to go really quick through that and just kind of get into the medications here real quick. Methadone is a long-acting opioid medication. It has about 2.5 times the half-life as a lot of our other opioids. So it's really, really useful in reducing cravings and withdrawals. Who is an ideal candidate? This is information that was provided through the Addiction Policy Forum, but ultimately it's up to the prescriber, the doctor, and the individual. You can only take methadone if you are going to an opioid treatment facility, which means that you have to go into the dosing clinic every single day. So as long as you're on methadone, there's no camping outside of your area that you can't just get to them that next morning for your dose, family reunion stuff. You're pretty much married to that clinic while you're taking this medication. The only exception might be a holiday or a weekend where if you've built up trust with them and you're showing them that you're not abusing it, they may send you home with 1 dose in a locked box that will tide you over a day that they may be closed. But other than that, you're pretty committed to being there. But whether or not this is an appropriate medication, again, up to the doctor, the prescriber, the treatment provider, and the client. It's up to them. So one of the other medications that we were talking about is buprenorphine. That is the key ingredient of Suboxone. It's a long-acting opioid medication that reduces cravings. And this is one that has to be prescribed by an X-waivered prescriber. It's a special training that the DEA requires prescribers to go through in order to prescribe this. And it's right now the most common because you can have a 5-day, 10-day, 30-day supply at home and not have to go into the clinic or the dosing clinic every single day. There's things that they're going to discuss, a health history, other, conditions going on. Again, that's between the doctor and the client, not for us to say, but those are just some of the things factors they'll be looking at to see if this is a good medication for that individual. And then naltrexone, which comes in a pill form or in a once-a-month shot called Vivitrol. And naltrexone is commonly confused with Narcan and naloxone, because Narcan is the commercial name for naloxone. That's the opioid blocker. So someone's experiencing an overdose, they're administered naloxone. That is different from naltrexone. Naltrexone is a complete opiate blocker. So, and it's also the only FDA medication approved for alcohol use disorder. And again, between them and their doctor on whether or not that's an appropriate medication, but it drastically reduces the risk of overdose and can be a very important part of an individual's recovery plan. And
Monica,
every state, yeah, we're out of time.
sorry to interrupt you. We do have 1 minute left, so I just wanted to get space to wrap up because we do have a hard stop.
Okay.
Folks, those of you that entered in questions, please put those in the evaluations. Again, since we won't have time to answer them now, I'll go ahead and turn it back to you, Monica, for wrapping up.
And I'm going to try and wrap up really fast. I do hope there is a lot of information in this PowerPoint, and it may create more questions for you. It is definitely a complicated topic to talk about and certainly to explore in 1 hour, but I would love to talk with you about this if you have any questions. If you review the material and want some more information, I'd be happy to get that to you through Empower Idaho if they forward that on to me. And I know Empower Idaho has a lot of resources of their own that would be helpful in helping you explore the science between opioid use disorder and the use of medication-assisted treatment. So I just want to thank you all for being here today, for your really great questions. I hope I was able to answer them, and I hope you have a great rest of your conference.
Yes, thanks, Monica, and thank you all for joining. Again, this recording will become available on our website, and it will also be shared with you through GoToWebinar. So please share your comments and questions in the evaluation, and we will do our best to do that follow-up. Thank you.